Support for Pupil Pod comes from Johnson & Johnson. Technis Eyehance IOL, defining the future of monofocals. Contact your Johnson & Johnson sales representative to learn more.
Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is Dr. Beeran Meghpara. Dr. Meghpara is a cataract, cornea, and refractive surgeon at the Wills Eye Hospital. Dr. Meghpara, thank you again for joining me tonight.
It's my pleasure, Sila. Thanks for the invitation. I'm looking forward to talking a little bit about a really interesting topic.
Well, you know that cornea is near and dear to my heart, so I'm definitely looking forward to this topic. So let's jump right into it. This is a 16-year-old boy with a history of a scaly rash on his elbows, who presents to your office with 1 month of photophobia and mucoid discharge in both eyes. His visual acuity is 20/25 OU, and he has been using some over-the-counter get the red out drops, which he says give him some relief. Now, Dr. Meghpara, I'm going to stop here since we already have a lot of important information. How would you kind of approach this patient based on the short history that you have right now? Anything specifically you'd want to ask or you'd want to know about?
Yeah, definitely, Sila. And, this is just a few sentences, but there is so much here that we should pull apart. So first of all, what I'm looking at is the age and the gender, and that always is going to kind of be a little bit of a clue. So we have a younger teenage boy, and he also has this systemic issue or this dermatologic issue of scaly rashes on his elbow. So anytime someone has rashes or itching or something along those routes, we're thinking atopic disease. Then let's move on to kind of the ocular complaints. So he has photophobia and mucoid discharge. It's bilateral, and it's been going on for a month. So that kind of gets me to think, what conditions cause bilateral discharge? And I guess the first thing that would come to mind is something infectious, right? So whether it's bacterial or viral, but 1 month of symptoms is kind of a long time for an infectious process, unless it's maybe, bilateral chlamydia or something like that. So maybe infectious is less high on our differential, but I'd ask him, has he had any sick contacts, anyone else around him with a red eye? These things could potentially be, clues that this is a viral infection. Did he have a recent cold? But again, I'm not too worried about something viral that's been going on for a month. So then let's take a step back. What can cause a bilateral conjunctivitis for a chronic amount of time? So what I'm really trying to figure out now with my history is, does this patient have any new exposures, whether that's something in the house, bed sheets, laundry detergent, something that, they've changed as far as cleaning materials go? Is it something environmental? Do they move to a new part of the country, or do they move into a new home? So kind of exposure related things can often cause chronic conjunctivitis. And then I kind of want to know, what is the time course here? And what I mean by that is, is this happening repeatedly? So did this happen last year? Does it happen the same time every year? And that can also kind of point us in one direction or another. And then finally, he's using these over-the-counter get the red out drops. I am not a big fan of those. Sure, they can get the red out and provide some symptomatic relief to patients, but these are vasoconstrictors, right? So the Visines and Clear Eyes of the world, they can cause what's called rebound redness or rebound injection. So patients often get dependent on these. So we really discourage our patients that they should not use these. And if they find that they're dependent on them, they should really come in for us to figure out what's the underlying problem and kind of help them through that. So that's kind of how I work through the history in these sorts of patients.
Whenever I hear get the red out, my whole spine kind of like realigns in the chair, and I have to take a deep breath and calm down before I say, we don't usually recommend those drops instead of like slapping it out of their hand, which is what I want to do. So, how would you kind of focus your exam of this patient? Obviously, we're going to do a complete exam, but are there some things that you're looking for specifically, and what would you make sure not to miss?
Yeah, so as cornea specialists, we like to jump to the cornea, right? So anytime someone comes in with any sort of complaint, we look at the cornea. But it's really important not to neglect the other parts of the ocular surface. And really, in this situation, it's really important to look at the eyelids closely. And even more important is to flip the lids. I honestly tell all of our residents, all of our fellows, that any cornea patient, no matter what they come in for, you got to flip the lids. And we're looking for palpebral conjunctival changes. Are there papillae there? Are they on the upper lid? Are they on the lower lid? How big are they? Is there scarring, cicatrizing changes, some blepharon? And then sometimes it could be something completely unrelated. We had a patient one day come in for a red irritated eye. We flipped the eyelid and found a bunch of contacts kind of lodged in the superior fornix. I think we pulled like 15 of them out. So super important to flip the eyelids, and then also look at kind of the bulbar conjunctiva very closely. Look for edema, and again, any kind of cicatrizing changes. And then, of course, look at the cornea. Are there any areas of staining on the cornea, frank ulceration, neovascularization? What does the limbus look like? So I kind of go from an out to in approach. And then, of course, we'll do a complete eye exam, like you said, looking inside of the eye, but really what we're focused on here is external disease.
So important. And flipping the eyelid, I think, is one of the things that I would always repeat to the residents because as a junior resident, I would always forget to flip the eyelid. I would look at the lower lid, see either papillary conjunctivitis or follicular conjunctivitis, and then call it and be done with it. But it's so important to flip the lid. You never know what you're going to find. You could find 10 contact lenses, you could find a foreign body, even without corneal epi defects. You just never know. So it's so important.
Not even flipping the lid, but also just pulling the upper lid up. Because a lot of times, if you just look at the eye, you'll miss something on the cornea, on the superior cornea or at the superior limbus. So things like SLK, things like that have a tendency to affect the superior areas of the surface. You got to just lift the lid and flip the lid.
Absolutely. So let's say on further questioning, you find out that this patient has similar symptoms every spring, pretty classic. And on examination, you note gelatinous opalescent mounds. At that point, what would be highest on your differential, and what other examination findings would you look for or kind of expect to see in patients like this?
All right. So we have, a young male with seasonal symptoms that occur every spring. And these gelatinous opalescent mounds that are located on the limbus, these are Horner-Trontus dots. So this is a pretty classic presentation for vernal keratoconjunctivitis, so VKC. So other things that occur in these patients. So we talked about these gelatinous dots, these Horner-Trontus dots, and what these are areas of degenerated eosinophils and epithelial cells that aggregate at the limbus. So that would be kind of the limbal variant of VKC. There's also the palpebral variant. And this is where it's really important to lift up the lids, we'll see these large areas of papillary hypertrophy, which is much more common on the upper lid and more prominent on the upper lid compared to the lower lid. And in certain cases, these can be really dramatic. The upper lid almost looks like a cobblestone with these really big giant papillae. And then if you look at the cornea, potentially you can get secondary corneal changes in these patients. So you can get punctate epithelial erosion, so corneal staining. You can get a superior pannus. And then you can get shield ulcers, which are these kind of sterile epithelial defects that have the appearance of a shield. That's how it gets its name. And these kind of correspond to these areas of giant papillae. It's almost like a frictional component that happens sometimes. And then in severe cases, you can get limbal stem cell deficiency and kind of conjunctivalization of the limbus and then abnormal epithelium from that.
Hopefully, this patient will have seen a cornea specialist and had some preventative care before it gets to that point. But it's such a good point that you make that it can progress to those severe late stages. So this patient is a classic case of limbal vernal keratoconjunctivitis. How can we distinguish more mild cases from, let's say, just run of the mill allergic conjunctivitis or atopic conjunctivitis? So, obviously, when it's severe and we have the shield ulcer and the cobblestoning or the giant papillary conjunctivitis, it becomes pretty clear. But what are some things that you think about when you're distinguishing these three different but intertwined diagnoses?
I mean, that's a really good point because they are different, they're distinct, and they do have classic differences, which we'll go over. But there's a lot of overlap in these conditions, right? So someone can have allergic components with vernal, or you could have vernal and atopic components. And it's the key to understanding these is what's the underlying issue. So they're all hypersensitivity reactions, right? Allergic is essentially only a type 1 hypersensitivity. So it's IgE mediated. It's mast cell degranulation with release of histamine. VKC and AKC, atopic keratoconjunctivitis, have an additional component. So there we have kind of a T cell mediated immunity too. So that's a type 4 reaction. And this becomes important in the treatment of the various conditions. But as far as kind of how do they present, so a patient with allergic conjunctivitis, probably the most mild on the spectrum, typically will present with kind of red, itchy, watery eyes. When you look at their conjunctiva, it has this kind of boggy appearance. You can get these changes to the lower lid skin. It kind of gets this bluish, grayish to purplish appearance, and we call those allergic shiners. And the key is usually there's some sort of trigger, right? So what are they allergic to? And this is kind of, your classic hay fever conjunctivitis. Patients go outside and they experience these symptoms. So that there's usually a trigger, and it's kind of itchy, red, watery eyes. When it comes to AKC, again, this is a type 4 reaction. And these patients typically have symptoms and disease all year round with minimal seasonal exacerbation. A few key points to distinguish AKC from VKC. And again, there's quite a bit of overlap here, or there can be quite a bit of overlap, but the classic teaching and what would be on the boards would be patients with AKC are typically older. When you look at the papillae, they tend to be smaller, so maybe smaller, medium size compared to the very large ones that you see in VKC. And they occur equally on the upper and lower palpebral conj. And remember, in comparison to VKC, those are predominantly found on the upper conj. You'll get kind of this milky conjunctival edema, and sometimes with AKC, you can get conjunctival fibrosis. The other kind of big distinguishing thing between AKC and VKC is what does the cornea look like? In AKC, we often find more severe corneal disease. So you'll get kind of extensive corneal neovascularization and kind of the subepithelial opacification. That's just chronic inflammation, chronic epithelial disease that leads to these changes. And maybe some component of like mechanical trauma from the eyelids. Cataracts are sometimes found in patients with AKC, specifically PSC or these shield-shaped anterior subcapsular cataracts. And I think one thing that's really important to know in an AKC patient is these patients have a higher risk of developing herpetic corneal disease. And that's because they have this almost deficiency in T-cell mediated immunity, and they tend to get herpetic disease more frequently. So if I ever see a patient with bilateral herpes, that is very unusual in a typical patient, but in a patient with AKC, that can happen sometimes. So if you see bilateral herpes, look for atopic conditions as well. The other associated disease with AKC is keratoconus. So always be on the lookout for ectatic disease. Now, there may be some correlation there between eye rubbing in AKC and keratoconus, but that's something that's very important to keep in mind. But the key is, sometimes patients with vernal can have year-round vernal, so it's not always seasonal. Sometimes patients with atopic can have disease that's prominently in the superior conjunctiva. So yes, these are good rules to follow, and especially for test questions, this is what you'll be asked. But kind of in the real world, sometimes there is overlap. The nice thing, though, is especially for VKC and AKC, the treatment is kind of the same.
So many good points there. And I just want to reiterate a couple of them, especially for the junior residents, because I remember seeing Shield and associating that word with VKC, and then later learning about the shield cataracts, the anterior subcapsular cataracts that you see in AKC. So that's one thing that I always like to distinguish early on for trainees. And then the bilateral herpetic disease, I think super important, especially with that decreased T cell mediated immunity. And so in those patients, really something that we like to think about. So you kind of already started alluding to the treatment of these patients. How would you treat this patient, and any differences in this treatment for the VKC patient versus maybe your AKC patient or your allergic conjunctivitis?
Yeah. Well, I guess let's first talk about what's common among all of them. Like, what should you do for any one of these patients? So, I guess first, if there is kind of um, something that's causing this, so if there is an irritant or an allergen, you want to try to avoid that as much as possible. Um, Kind of your classic allergy drops, those are usually kind of mast cell stabilizers or antihistamine drops. And there are some combination drops that are out there, like, ketotifen or olopatadine, so Zatador, the Pataday family, Bepreve. These do a good job of treating that type 1 IgE related hypersensitivity. So for your allergic conjunctivitis patients, that's a nice way to provide symptomatic relief. One thing you do have to be careful for is a lot of the um, medications in this class, the antihistamines, they can cause secondary dryness. So if you have a dry eye patient and you put them on a topical antihistamine, you have to be careful about that. One fun fact, the only antihistamine that does not have dry eye as an adverse event is cetirizine. So that's Zerviate. It's the same medication that's in Zyrtec, but that's kind of a fun fact. That medication actually doesn't cause dry eye.
Oh, that's so interesting. I'm actually learning that for the first time. I've never told a patient to get that. I usually stick to olopatadine or just like our standard Pataday, but I don't ever tell them to get the topical cetirizine. That is something that I'm going to add to my clinical practice.
Yeah, it's a little tough to get from kind of insurance standpoint, but yeah, if I have a dry eye patient, I try. Um, but
Is
then
it
so now,
available over the counter?
no, it's prescription.
Okay, prescription only. Okay, good
Yeah,
to
it's
know.
prescription.
Good to know.
So that's kind of our allergic patients, and you can use these medications for VKC and AKC patients, but really the the bigger issue in VKC and AKC is dealing with that type 4 T cell mediated immunity, right? So that hypersensitivity. So there we have to decrease inflammation, and really it's a two-step process. It's one, treat the kind of acute flare that's going on to get the symptoms better, and then two, keep things under control kind of at a baseline. And that's true for VKC, but especially true for AKC. So for example, in this patient, quite bothered for a week, a lot of times what I'll do is I'll do a short course of pulse topical steroids. So whether it's fluoromethalone, loteprednol, even prednisolone acetate, um, just a short course, maybe a week's worth. You do have to be careful in these patients who are typically young. You don't want to keep them on prolonged steroids. We don't want to give this young patient a cataract who already potentially may be predisposed to getting a cataract. But these conditions respond quite well to topical steroids. But the second thing that we do is we put them on an immunomodulator. So cyclosporin and lifitegrast for a long time were used off-label because those are typically dry eye medications. So we would use those off-label 2, 3, 4 times a day to help control that T cell mediated immunity. Now we actually have cyclosporin 0.1% that is FDA approved for the treatment of VKC and AKC. It's dosed 4 times a day, and patients can use this long term. So I usually do a two-step approach. Put them on a steroid, especially if they're really irritated, lots of discharge. If I'm worried about corneal changes, if I'm worried about neo and scarring, low threshold for a steroid, and an even lower threshold to put them on a topical immunomodulator.
So, in those patients, do you just forego mast cell stabilizers since this is primarily a type 4 hypersensitivity reaction and really just focus on steroids and immune modulation?
I do, unless they have a big component of like itchy, watery eyes. Because in that situation, I do think the antihistamine and mast cell stabilizer does help, but that is just in select patients. And a topical steroid will do a lot of that too, right? So I don't like to kind of inundate these patients with drops as well, right? So almost like glaucoma patients, sometimes less is more. You get more bang for your buck with a steroid and immunomodulator.
Absolutely. And I mean, we're so lucky to have all of these excellent treatment options, but the last thing that we want to do is throw 10 things at the patient, not know which one is working, and then potentially have them only using two out of the four. And it's the two we don't really want them to use as much as the other two, which I've had
Yeah,
happen countless
exactly. And
times.
these are kids, right? So kids, it's hard enough
Yes,
to get them
exactly.
to use one medication, let alone two or three or four.
Absolutely. I mean, I'm a kid in my mid 30s, and it's hard enough to get me to take medications. So, all right, Dr. Meghpara. So, how would you counsel this patient about their prognosis and follow up? And what would you tell them about kind of what you expect?
So I would counsel this patient that, well, one, it's almost a relief that we're giving him a diagnosis. We have an explanation as to why he's feeling like this every year at this time of year, because they can be kind of annoyed by this fact. But then we do also kind of have to discuss this is a chronic disease, and it is going to require kind of long term treatment and long term follow up, especially if we're going to put him or her on a steroid. And we'll talk about the side effects of increased eye pressure, the increased risk of cataract formation. If it's an AKC patient, the increased risk of a herpetic flare. And I'll talk to the patient and their parents, so that if they find that they're getting worse on these medications, they need to call us and come in. But typically, I'll treat them their acute episode with the steroids, start that immunomodulator, have them come in a couple of weeks just to make sure they're getting better, and then spread out the follow up. And I'll see these patients if they're stable, maybe once preemptively in the beginning of the year. We'll try to figure out when they're getting worse, or when is that time when their symptoms will start to develop, and kind of get them in then and make sure they're taking their immunomodulator. Because in an ideal situation, if we get them on the correct maintenance treatment, then they may not need steroids. So I mean that's the key, just educating, talking about side effects, and making sure that they know that they're going to have to come in, kind of ongoing for follow up and for care.
And I think just so important, one of the first things you said was just letting them know that we can manage this, but this will be something chronically that they'll have to deal with. And setting those expectations early on, I think is so important to build that relationship with the patient. So this was a great episode. We definitely learned a lot about three of the immune mediated diseases of the conjunctiva. But before we end the episode, I like to ask all of my guests, if you could have dinner with one person from any time or place in the history of humanity, who would it be?
So I am a huge sports fan. I'm a huge baseball fan, actually. So probably the one person I'd want to have dinner with, just to see what it was like when he kind of broke through, would be Jackie Robinson. Just to kind of sit down and have him tell me what that experience was like. So I'd have to say Jackie Robinson.
Great answer. I don't think we've had any professional athletes mentioned yet, although I might be wrong. since I don't know very many professional athletes, but I do know Jackie Robinson, so I at least can hang my hat on that.
Yeah, I guess for
Dr.
those of you who don't know who Jackie Robinson is, he was the first African American to play baseball. So we got a lot of smart people tuning in here. Maybe not too many, people that are super into baseball. So
Dr. Meghpara, thank you so much for joining us on this episode of the Pupil Pod. Always super fun to talk about anterior segment, cornea, conjunctiva, all of that. And it was really a wonderful episode. So thank you again.
no, it's my pleasure. So I had a lot of fun.
And thank you to those tuning in. See you next time on the Pupil Pod.